Let's start CVS with first describing pericardial disorders. So you have two main disorders: cardiac tamponade, which is acute. So you have massive or rapidly filling pericardial effusion. So in constrictive pericarditis, it is chronic sequelae of pericardial effusion, most commonly because of tuberculosis. Okay, 100% of all effusions, they will progress over a chronic period into constrictive pericarditis. It is chronic. Okay, so pathophysiology, see, basically when you have acute large filling in the pericardium, it compresses your ventricles such that they cannot be filled with blood. Okay, the lumen size decreases, they cannot be filled. So it is a ventricular filling defect. So that is why left ventricle, it cannot be filled. Okay, early filling phase is affected. So because left ventricular pressure is decreasing because it's not filled with blood, there is equalization of pressures. So left ventricle resembles right ventricle in pressure. There is equalization of ventricular pressures. Okay, so clinical features, you'll have Beck's triad. So you'll have hypotension, enlarged neck veins, and muffled heart sounds. Okay, hypotension, increased JVP, so elevated JVP, so pressure increases. Hypotension, BP decreases, and then muffled heart sounds. So on examination, so Y descent is absent in JVP, that is important in here in cardiac tamponade, and Y descent is exaggerated in constrictive pericarditis. And remember three things: pulsus paradoxicus, Kussmaul sign, and heart sounds. See, heart sounds are muffled here, and here you will find a pericardial knock in constrictive. Okay, knock. Next, pulsus paradoxicus is common in cardiac tamponade. It is present only in 30% cases in constrictive pericarditis, but Kussmaul sign is absent here. Kussmaul sign is present in constrictive pericarditis. Gold standard is echo. See, here in echo you will find pericardial effusion, lot of fluid, more than 200 ml, and most specific finding is early right ventricular diastolic collapse. See, in diastole your ventricle is supposed to fill with blood, okay, but it's not filling, so there is collapse. Okay, treatment and prognosis, you will do emergency pericardiocentesis. So again in constrictive pericarditis, again you have a thickened pericardium. Okay, so predominantly affects the late filling phase, A. Here early, here late. Okay, so that is why in the next cardiac cycle there will be exaggerated early filling phase. So clinical features, what will you have? You'll have palpitations, so risk of tachycardia and tachyarrhythmias, and along with that you'll have hypertension and heart failure in advanced cases, but mostly palpitation. Okay, against the thickened pericardium, your heart tries to contract, exaggerated early filling phase. Okay, so JVP, Y descent is exaggerated. Pulsus paradoxicus only in 30%. Kussmaul sign is common. Kussmaul sign is common in chronic constrictive pericarditis. Okay, then see, you can remember it like K. K comes much longer after C. Okay, so chronic Kussmaul sign. Okay, next heart sounds, you'll hear a pericardial knock. Next echo, you'll find a thickened pericardium, and also see exaggerated early filling phase. Mainly A is affected, so ratio E is increased, A is decreased, so ratio is greater than 2, E is to A ratio. It is more specific on echo. So surgical resection of the pericardium is the only potential cure. So here moving on to the book. So pericarditis is inflammation of the pericardium. Just talk about two layers: parietal, visceral, which is pain sensitive, which is pain insensitive. There is a fluid. Okay, so it provides lubrication, prevents deformation to the heart and all that. Okay, so acute inflammation less than 6 weeks to the pericardium is acute pericarditis. So immediately you will have idiopathic, you'll have infectious conditions of viral, bacterial, fungal, all this fungus, you have dimorphic fungi, and inflammatory. See, bacterial, you have streptococcus. So again you will have rheumatic fever. Along with rheumatic, so catch the rheum, and rheumatoid arthritis, SLE, you will have connective tissue disorders as well. Next, metabolic disorders, you have something called uremic pericarditis. Okay, and hypothyroidism also you can have. And Dressler syndrome is post MI. So then during MI you can have pericarditis as well. Miscellaneous causes, some neoplasms also can cause. And what are the clinical features? See, there is pericarditis, there will be pericardial pain, which is sharp, retrosternal or left precordial, sometimes referred to the back and left shoulder. It is relieved by sitting forward, so patient leans forward. That is why when the patient leans forward also you can appreciate the sound more. Okay, what sound? Triphasic pericardial friction rub. So atrial systole, ventricular systole, and ventricular diastole, all these phases you can find a triphasic pericardial friction rub. Okay, it can be heard as biphasic to and fro rub. Okay, corresponding to systole and diastole. Triphasic and biphasic to and fro. It is high pitched scratching or grating. Okay, like this. And it is better heard with the diaphragm at the left lower border of the sternum, with the patient leaning forward at the end of expiration. Okay, so what are the investigations? See, basically you'll do TLC, all these blood investigations, ESR, and ECG. ECG in pericarditis, in acute pericarditis, you will find concave ST elevation or saddle ST elevation. So saddle, okay, acute pericarditis. Pericardium is something on which your heart sits. Okay, so sit, saddle. Okay, so PR segment is depressed and low voltage QR complexes and electrical alternance may be seen. Okay, low voltage QR is because your ventricle is not able to pump that much blood, so ventricular depolarization, all that, it decreases. Okay, so cardiac enzymes may be normal. Chest x-ray, you can see pericardial effusion or widening of the cardiac shadow if it is there. And obviously pericardiocentesis, if you take out any fluid, you will do microscopy, cell count and all that. Okay, next CT MRI of the heart should be done. Then management, so pericardial inflammation can be decreased by using NSAIDs. Okay, anti-inflammatory. Next, you can use steroids as well in resistant conditions. Okay, next, treat the underlying cause. Constrictive pericarditis. See, causes, basically you have TB is an infection. You have other bacterial infections, rheumatic fever, based on that again rheumatic, so rheumatoid arthritis, SLE. And again irradiation also can cause constrictive pericarditis, chronic irradiation, and chronic condition is neoplasm. Okay, these are the etiology. So basically we said on this half we studied that it was a late phase was being affected and early was being exaggerated. Okay, but basically because of adhesions and all that, your heart was not able to pump too much blood. Okay, so there was congestion, so ascites, dependent edema, hepatomegaly, rise JVP, all all reduced ventricular filling. Because of that, right side heart symptoms you can see. And also pulmonary venous congestion, it produces dyspnea, cough and PND. Okay, reduced ventricular filling, again because of left failure, you can see hypotension and reflex tachycardia. Okay, small sign pulsus paradox, because we talked about this. Pericardial knock, okay, on heart sounds. And chest x-ray, see there can be pericardial calcification. ECG, because the ventricle is not able to pump blood, you are finding symptoms like fatigue, hypotension and all that. But here, because the ventricle is not pumping properly, you'll have low voltage QRS complex and generalized T wave flattening or inversion, because the ventricle is not able to fill. Okay, so T wave repolarization, ventricle will fill in that time. So T wave flattening or inversion. Okay, echo, you will see calcified pericardium and all that. CT MRI can be used. Treatment, pericardial resection, you strip the constrictive layer. Okay, that is important. In case of tuberculosis, you will give ATT. Okay, then tuberculous pericarditis, same. Low grade fever, weight loss, you'll write symptoms of TB, you'll write symptoms of pulmonary TB, you'll do chest x-ray also, Mantoux test and all that. But basically everything resembles constrictive pericarditis. If it is acute, you'll aspirate it, and pericardial biopsy, it will show granulomas. Okay, you'll give ATT and steroids. Then cardiac tamponade, so again excessive filling of blood. Okay, it can be basically it can lead to pulmonary edema, shock and death. So sometimes you can find lymph and blood also. So etiology is the same as acute pericarditis. We talked about all these situations, right? So they're there. And clinical features, so it can present with see, basically you'll have Dextriad, so decreased BP, so hypotension, increased JVP, so distended neck veins, and you'll have muffled heart sounds. Okay, and Kussmaul sign, and Kussmaul sign is absent, and you'll also have pulsus paradoxicus and muffled heart sounds. Okay, Y descent is absent in JVP. Okay, you can hear a pericardial rub sometimes in early stages, but as the fluid increases and separates the pericardial layers, you can't. Apex beat, again it is obscured. Next, you can have something called Ewart sign. So base of the left lung may be compressed by the pericardial effusion, producing an area of dullness. Next, you can, if there is cardiac tamponade, so you'll have hypotension, dyspnea, orthopnea, raised all this Bextriad and all that. So ECG, again low voltage QRS complexes. Chest X-ray, it shows a large globular or pear-shaped heart, so water bottle appearance. So again pericardial biopsy, pericardiosynthesis, all that you can do. Pericardial biopsy only if you're suspecting TB. So underlying cause you treat it. Again basically what you'll do is emergency pericardiosynthesis. Okay, relieve the pressure. Moving on to infective endocarditis, see healthy intact endocardium, it cannot be infected. So there are certain predisposing conditions causing endocardial injury. So congenital heart disease, chronic period of time, so any VSD, okay, that can cause infective endocarditis, continuous injury to the endocardium. So valvular heart disease, so most commonly mitral valve prolapse. Okay, so prosthetic valves or any IV drug abuse or intracardiac devices. So all of them, they predispose to injury. So causative organisms, again see, basically you can divide it into native valve endocarditis and prosthetic valve. See, so native valve, you have Streptococcus viridans and Staph aureus, and Hasek organisms, Haemophilus, Aggregatibacter, Cardiobacterium, Echinella, Kingella. Next, healthcare associated. So within 60 days of hospital admission, so you can have MRSA. Okay, this goes here. So MRSA and Pseudomonas or Candida mycotic. Okay, so then prosthetic valve, within one year of procedure you can have cons and staph epidermidis. Okay, and after 1 year, same again like native valve, so you can have streptococcus, staph aureus, all that. Most commonly in India, staph aureus. Overall most common MSSA. So pathology. So and first there is endocardial injury because of all these predisposing conditions. Then the healing occurs by fibrin-rich clot formation. This is NBT, non-bacterial thrombotic endocarditis. Then because of some transient bacterium after any post-dental surgery or fever, all that. So these organisms, they bind to the clot and there is platelet aggregation. This leads to infective endocarditis, vegetation. See, then the sequelae. First, vegetation, it can spread directly to the surroundings, endocardium near the valve. So there can be dehiscence of the valve or the prosthesis. This can present as regurgitation. The valve is gone. Okay, so acute MR or AR. So prosthetic dysfunction, something like that, acute heart failure. Then this is infecting the valve, regurgitation. Next, around the valve, paravalvular abscess. There can be myocardial spreads or sepsis. Okay, there can be ring abscess or myocardial infarction, myocardial abscess, something like that. Then vascular embolization of the infected clot. See, the emboli, the vegetation in the clot, it can go to the brain, form multiple abscesses, kidney, flea bitten kidney, spleen. Okay, then peripherally, it can produce Janwell lesions on the palms and the soles and splinter hemorrhages. Okay, and also intracerebral hemorrhages due to mycotic aneurysm rupture. Okay, so it can rupture in the brain, it can rupture here, Janwell lesions, it can rupture in the skin, splinter hemorrhages, it can infarct the brain, kidney and spleen. Next, immune complexes. You have Osler's nodes, which are Osler's nodes, rod spots. Okay, again joint involvement, arthralgia and glomerulonephritis. So then diagnosis is by modified Duke's criteria. See, first in major criteria, you have two. You have two. So bacteriological evidence and echo evidence. Okay, so bacteriological evidence. See, you need to have two separate blood cultures positive for typical organisms or two separate blood cultures drawn 12 hours apart. And then one blood culture positive for Coxiella, fastidious organism, or if there is serology, 1:800 IgG titers of Coxiella, that is positive bacteriological evidence. Two blood cultures separate, two blood cultures 12 hours apart, then one for Coxiella and 1:800 for Coxiella. Then positive echo evidence. So if there's a new regurgitant lesion, okay, if there's any paravalvular abscess, if there's a prosthetic valve and it is oscillating, so oscillating intracardiac mass and partial prosthesis, dehiscence. Then 5 minor criteria. Say there's an infection, so you will have fever. You'll have vascular phenomenon. So what do you have? You have Janwell lesions, splinter hemorrhages, then immunological, rod spots and Osler's nodes and all that. And blood culture is positive but not as enough as major criteria, and also some predisposing conditions like IV drug abusers and all that. So 2 major or 1 major plus 3 minor or all 5 minor, that is positive. So again, treatment. First line, you will give empirical IV antibiotics for 3 weeks minimum. Okay, so naive valve endocarditis, what you'll do is you'll give IV penicillin plus third gen cephalosporins. Okay, then if it is exposed to healthcare, you will add gentamicin, penicillin, cephalosporin plus gentamicin. So penicillin, ceftriaxone plus gentamicin. Okay, then suspected MRSA is there means vancomycin. Then again, if the MRSA is very critical or going into renal failure, then give linezolid. It could be vancomycin resistant. Okay, then again, prosthetic valve endocarditis, you add rifampicin also for cons. Next, specific indications for surgery. See, if it is an emergency situation, you need to go for surgery within one day. Okay, so if it's an acute MR, acute AR, going into heart failure, all that. Next, elective, within 1 week. Okay, so vegetation, if it is increasing in size, so greater than 10 mm, mycotic endocarditis, it can rupture in the brain, hemorrhage in the brain. Then resistant organism on culture sensitivity, or if there is a prosthetic defect. Then after 10 days also you can go if the blood culture is still positive after 7 days of appropriate antibiotics. And again, prophylaxis. See, you need to give prophylaxis for infectious endocarditis, especially if you are undergoing any procedure after you know that you have a previous history of endocarditis. See, if it's a partially repaired cyanotic heart disease, already history of endocarditis, if there's a prosthetic valve or surgical repair of the prosthesis. So those are conditions. And treatment, you will give single dose 2 grams amoxicillin 6 hours before the procedure. Okay, especially before any dental surgery or major GI or gynecological surgery. So you can draw splinter hemorrhages like this, Osler's nodes like this. Okay, and again, you have all these blood cultures. But echo, see, transesophageal echo is more sensitive than TTE. Okay, that is important. Transesophageal is more sensitive than transthoracic. And again, all these other tests you have. And see here, infective endocarditis, first, if it is a native valve endocarditis, you will give vancomycin plus gentamicin, VG. Prosthetic valve, you will give rifampicin as well, because rifampicin, it penetrates the biofilm also, especially in cases of cons. Okay, prosthetic valve endocarditis. Native valve, you will give VG. Prosthetic, you will give VGR. So if it is streptococcus, you will give you will give BG, benzyl penicillin and gentamicin, or CG, ceftriaxone and gentamicin. So that is what we already discussed. So ceftriaxone and gentamicin as well. Okay. So naive valve, you can just give benzyl penicillin or ceftriaxone. Then enterococci, you will give AG or VG, ampicillin and gentamicin or vancomycin gentamicin. So that also we discussed. And staphylococci, benzyl penicillin if it is penicillin sensitive, and vancomycin and gentamicin if it is resistant. Okay. Moving on to complications of infective endocarditis. See, you have heart failure, again most commonly, and embolization. This brain and spleen can be affected, and mycotic aneurysm rupture in the brain, periannular extension of the infection, and renal dysfunction, flea-bitten kidney and all that we saw. Okay, and again prophylaxis, we already talked about the conditions requiring prophylaxis, but also additionally what you have is, you have amoxicillin 2 grams single dose around 1 hour before the procedure. But if he is unable to take oral medication, you give ampicillin. Okay, 2 grams IM or IV. Everything 2 grams only except ceftriaxone, which is 1 gram. So if he is allergic to penicillins, can take orally, give cephalexin 2 grams. Allergic to penicillins and ampicillin and unable to take orally, so ceftriaxone 1 gram. Also have something called Liebman-Sachs endocarditis. It is verrucous, merantic or non-bacterial thrombotic endocarditis. It is seen in SLE and APLA. So the verrucae are common on both aortic and mitral valves, and both atrial and ventricular sides of the valves. So healing leads to fibrosis, scarring and calcification. They can cause recurrent lesions. Moving on to rheumatic fever. So basically rheumatic fever is an autoimmune inflammatory process that develops as a sequelae of group A beta hemolytic streptococcus infection. So group A beta hemolytic streptococcus infection, so GABHS. So basically children of age group 5 to 15 are involved, 5 to 15 years of age. So it follows a GABHS infection. It occurs 2 to 3 weeks after the attack of pharyngitis. Okay, so usually they have history of sore throat. So skin infections can also be, they are not associated with rheumatic fever. They can cause PSGN, post-streptococcal glomerulonephritis. Okay, but here only sore throat history you should ask. Pharyngitis, and serotypes causing them are 3, 5, 6, 18 and 24. So basically pathogenesis. So you have the upper respiratory infection, and then after 2 to 3 weeks, then after the infection, upper respiratory infection, body produces immune response against the M protein of the streptococci. Okay, so it produces antibodies. In few people, these antibodies have molecular mimicry. They cross react with cardiac proteins. So this antibody plus complement, it recruits macrophages. At the same time, your body also activates CD4 helper T cells, which also recruit the macrophages and cause them to become activated macrophages. Ultimately, there is destructive pathology in the heart. There is a collection of activated macrophages called Anitschov cells. Okay, Anitschov cells. So these Anitschov cells, along with T cells and fibrinoid necrosis, they form the Askov body, which is pathognomic of acute rheumatic fever. Okay, so Anitschov cells, you can see caterpillar chromatin because it is paler. Okay, so it is euchromatin active. Then acute RF, Askov bodies are formed. Okay, so that is important. So that is all about the pathogenesis. So pathogenesis, again, host factors also play a role. You have HLA class 2 alleles, so they have been identified, they have an association. Along with that, there is destruction, so interleukins are increased in the heart. And also basically along with the streptococcal membrane antigens, they also cross-react with the neurons of the caudate and subthalamic nuclei. So that is why you can see Sydenham's chorea. So in pericarditis, you can see bread and butter pericarditis grossly. So you can see thick exudates. So it heals without any sequelae. Then in the myocardium, you can find Askov bodies. Okay, so they have an ovoid nucleus, and so caterpillar nucleus also. And Askov nodule, it consists of central area of fibrinoid necrosis surrounded by lymphocytes also and Danitsko cells. Okay, again, so all of this you can see destructive processes. Endocardium, you can see small vegetations 1 to 2 mm in diameter on the atrial surface of the valve margins and the chordate tendinae. Okay, you can see on the atrial surface verrucae and vegetations. Okay, and you can also see something called a McCallum patch on the posterior left atrial wall, especially if there is mitral regurgitation. So because of the regurgitant jet, there is McCallum plaque which is formed in acute rheumatic fever. Okay, so that is there in the endocardium. Again, healing leads to fusion of the chordae, so chronic it becomes stenosis. So extracardiac lesions, you can have all these other features, so sore throat. Cardiac lesions, you already talked about this. You can have something called Carey-Coombs murmur. Okay, so and then again you can have regurgitant lesions in acute and stenotic lesions in chronic, and myocarditis also you can have, pericarditis, so basically pancarditis. Okay, because of pericardial effusion you can have muffled heart sounds, pericardial friction rupture in pericarditis and all that. In myocarditis, again cardiomegaly can be there, congestive heart failure also. Okay, then polyarthritis. See, it is migratory polyarthritis. Joints are involved in quick succession. Large joints are involved. Small joints are rarely involved. Okay, it responds dramatically to salicylate therapy. So it subsides spontaneously in 1 week, and the entire bout, it rarely lasts more than 4 weeks. Okay, then rarely Jacquard's deformity of the MCP, metacarpophalangeal joints, can occur after repeated attacks of rheumatic fever. Then you can have subcutaneous nodules. So basically they are round, firm. Okay, they are painless and freely movable. Okay, so they occur over the bony surfaces of the extensor aspects, so elbows, knees, wrists, etc. And you can have erythema marginatum. So this rash is found on the trunk and the proximal parts of the extremities, on the proximal region. Okay, the face is spared. Okay, then it appears as an erythematous macular papule with a clear center. Okay, they are not pruritic, non-indurated, they blanch on pressure. Then you can have chorea as well, so rapid purposeless involuntary movements, most noticeable in the extremities and the face. So moving on to Jones criteria, this is very important. So you need to remember, you have bread and butter type of pericarditis. So pancarditis, arthritis, migratory polyarthritis, Sydenham's chorea, subcutaneous nodules, and erythema marginatum. These are the 5 major criteria. So again, you divide it into low prevalence and high prevalence. In low prevalence, acute rheumatic fever incidence is less than 2 cases per 1 lakh school kids. Greater than 2 cases per 1 lakh is high prevalence. So that is why major criteria: arthritis, you will take polyarthritis in low prevalence, but in high prevalence you will take even the minor findings like monoarthritis, polyarthralgia, polyarthritis. Okay, treatment is aspirin. You just give aspirin for the arthritis and you will have very good response, around 75 to 100 ml per kg per day. Then next you will have pancarditis, most common cause of death. So most commonly layer effect is the endocardium. So acute you will have MR, chronic or rheumatic heart disease you will have MS. So characteristic murmur of acute rheumatic fever is Carey-Coombs murmur. It is a mid-diastolic murmur, CCD, Carey-Coombs diastolic, mid-diastolic murmur. So again, to reduce the load on the heart, you will give diuretics, and if the patient is not responding, you will give steroids. The next, Sydenham's chorea, because of IgG against the basal ganglia and the cerebrum. So it's a late manifestation. It takes more than 1 month, as IgG antibodies, they take time to reach the basal ganglia and cerebrum in the brain. So what are the findings? So first, in females you'll see more chorea, dancers. Okay, females, something like that. Chorea means dance. So you'll see external hand rotation. Okay, you'll find a scooping action. Okay, and then you'll find tongue fibrillation, so bag of worms finding, and also milking action, especially you can see that, and it decreases in sleep. Okay, so again you will give sedation therapy. Okay, so with valproate or IVIG. Next, subcutaneous nodules, they are seen on the extensor surfaces. They are non-tender, up to 2 centimeters, no need to treat. Erythema marginatum, you can see on the trunks and extremities, never on the face. Okay, so on the proximal areas, and again treatment is not needed. So this is the major criteria. So next, minor criteria. See, again infection is there, so fever will be there. Arthritis was major, arthralgia is minor. Then again ESR and CRP, obviously blood investigations. See, because of pancarditis, okay, the AV node can also become edematous, and then PR interval can increase. Okay, so that is why PR interval will increase in both, CRP will increase in both. But here, see, fever in low prevalence, you need to take a higher threshold, right? So to avoid unnecessary diagnosis. So greater than 38.5 degrees Celsius, high prevalence greater than 38 degrees. Low prevalence polyarthralgia, high prevalence even monoarthralgia, you can take as minor criteria. ESR greater than 60, and here it is greater than 13, high prevalence. Okay. So essential criteria is evidence of prior streptococcal infections, any history of throat infection, or rapid antigen test for streptococcus, or ASO titers are elevated, or throat culture is positive. So initial episode 2 major or 1 major plus 2 minor. Recurrent, so 2 major or 1 major plus 2 minor or 3 minor. Okay, along with essential criteria. And essential criteria is not needed if chorea is present. Okay, so moving on to the treatment of rheumatic fever. So in treatment, you need to keep the patient on strict bed rest, keep monitoring the vitals and all that, then give antibiotics. Even though evidence of active infection is unusual during the acute phase, you still recommend giving 10-day course of penicillin V. Okay. Then anti-inflammatory drugs, NSAIDs for the joint pain, aspirin is very effective. Then cardiac failure is managed by diuretics, ACE inhibitors, beta blockers, or if the patient is not responding, you give steroids. Then moving on to the prevention. Okay, so basically prophylaxis, you can divide it into primary and secondary prophylaxis. Primary prophylaxis, you give single dose of benzathine penicillin within 9 days of pharyngitis. Okay. And then secondary prophylaxis, basically you will give benzathine penicillin every 3 weeks. See, if the patient has no carditis, do this till 5 years or till 21 years of age, whichever is longer. Okay. And see, whichever is longer, you will choose that as secondary prophylaxis. So no carditis for 5 years or till the patient achieves 21 years of age. Carditis, so double it, 10 years or till the patient becomes 21 years of age. Then rheumatic heart disease in India, you give lifelong or 10 years or 40 years. Okay, so that is about rheumatic fever. Now let's start discussing valvular heart disease. So mitral stenosis, there is narrowing of mitral valve area. Normally it is 4 to 6 centimeters square. If for symptoms to occur, it should be less than 2.5 centimeters square. It is severe if it is less than 1.5 centimeters square. Okay, this is important. 4 to 6 is normal, less than 2.5 symptomatic, less than 1.5 severe. So epidemiology. So young females are mostly affected, that too in pregnancy. Okay, pregnancy it is considered as severe. So etiology. See, you can have rheumatic cases. Okay, carcinoids. So basically the vasoactive amines secreted by the carcinoids, they can come and they can compress your mitral valve. Okay, so just remember like that: rheumatic fever, carcinoid, and Lutembacher's. So there is congenital ASD. Along with that, there is associated MS. Okay. So what happens is mitral valve is stenosed, it is closed like this. So atrium cannot pump blood into ventricle. So atrium is enlarged. Okay, left atrial dilatation. So rarely you can have Ortner's syndrome. Okay, so then basically there is backflow. So pulmonary venous hypertension, pulmonary capillary hypertension, pulmonary arterial hypertension, and finally it is transmitted to right ventricle. So right ventricular hypertrophy, and finally you will have heart failure in late stages. So most common manifestation is fatigue. So young females usually they'll present with fatigue. But one common symptom is hemoptysis, because there is a lot of pulmonary congestion. Okay, pulmonary edema. There is also increased risk of LRTAs, and there is capillary rupture as well. Okay, all of this causes hemoptysis. One manifestation which is unrelated to severity is atrial fibrillation. You can have it in early and in late cases of MS. See, on examination, see, MS, okay, mainly S1. Okay, so loud S1. So because of palpable S1, loud S1, you can also palpate the S1. You'll have tapping apex. Okay, and you'll also have an opening snap because the mitral valve is so close. Left side pressures are anyway high. So you're trying to open, finally opening snap. Okay, so loud S1 with opening snap. And remember it as MSD, Mahendra Singh Dhoni. Okay, so remember it as MS, you'll have mid diastolic murmur. So MS, MDM. So on expiration with no preceding plop, left atrial myxoma also resembles MS. Okay, so MSD, remember Mahendra Singh Dhoni. So in MS you'll have mid diastolic murmur with presystolic accentuation, that is important. And you'll also have an opening snap and loud S1, MS mainly S1. Okay, and then ECG you'll have P mitral and also signs of right RVH. So you'll have right axis deviation, right bundle branch block, etc. Gold standard is echo. So moving on to treatment, see, you have to look at NIHA class. So 1 to 2 is mild, 3 to 4 is severe. So severe is associated with pregnancy, as I already said. And again, mitral valve area less than, it is still less than 1.5. Mild is, it is greater than 1.5. Left ventricular ejection fraction is preserved, greater than 50% in mild. It is reduced in severe. Okay, there are no signs of heart failure in mild. There are signs of heart failure in severe. So mild, you'll treat it with medical management alone. So palliative, you give diuretics and ACE inhibitors to reduce the load on the heart, and also if you are going to undergo any procedures, you'll give some antibiotic prophylaxis. But intervention, see, you'll do balloon mitral valvotomy. It is most preferred. Okay, it's a daycare procedure, but dreaded complication is acute MR. Okay, so you are opening the balloon. So again, the balloon, it can dilate too much. You can have MR in MS. So mitral valve repair only if BMV is contraindicated. When is it contraindicated? See, if it is absolutely calcified and there is severe associated mitral regurgitation along with the stenosis, you will not do balloon valvotomy at all, because the risk itself is acute MR. Then relative, again, if there's a thrombus within the left atrium, so you will not do. So before doing this procedure, that is why you will do transesophageal echo and you will see for any clot. Okay, so overall prognosis is good. So we'll look at the same thing in the textbook. See, MS, again, starting with the causes. So again, rheumatic heart disease, congenitally you can have, and carcinoid tumors. You can have it in SLE and rheumatoid arthritis and amyloidosis as well. Okay, pathophysiology, all this we discussed this already. Clinical features, okay, fine. Physical examination, you'll have something called mitral phases or malar flush. Okay, so this is a bilateral cyanotic or dusky pink discoloration over the cheeks, malar, okay, due to AV anastomosis and vascular stasis. And mitral stenosis, the left heart is pumping less blood, so you'll have low volume pulse. Okay, it may be irregular due to atrial fibrillation. Okay, then you'll have prominent A wave in JVP because of pulmonary hypertension. Okay, because A wave is produced by atrial contraction, right? So your atria trying to contract a lot. Okay, so you'll have prominent A wave. Next, cardiac apex is tapping. Why? Because mainly S1, MS. Okay, S1 is palpable, so that is there. Because of right ventricular hypertrophy, you can have a parasternal heave as well. Okay, and yeah, also in symptoms, by the way, because of left heart failure, you can have orthopnea, PND, all this also. And yeah, so basically, loud first heart sound, opening snap, and Mahendra Singh Dhoni, so mid-diastolic murmur with pre-systolic accentuation. See, it's a low-pitched mid-diastolic rumbling murmur. It is better heard with the bell, with the patient lying in the left side. So see, basically, you'll take the gap between opening snap and S2 and lesser the gap between opening snap and S2 if the severity is more. Okay, and also pulmonary hypertension can cause pulmonary valvular regurgitation, resulting in an early diastolic murmur in the pulmonary area known as Graham-Steele murmur. Pulmonary hypertension, so in pulmonary area, you'll have Graham-Steele murmur. It is an early diastolic murmur. Okay, other findings, you can have tender hepatomegaly because of right heart failure, pleural effusion and all that. So complications, you can have atrial fibrillation. It is not associated with severe treatment, can come in early or late mitral stenosis. Pulmonary hypertension, right heart failure, recurrent chest infections, hemoptysis, all of this. Okay, so chest x-ray, you can see left atrial enlargement. Okay, so there is straightening of the left border of the heart and double density at the right heart border due to combined shadows of the right atrium and the left atrium. Okay, so you may also see curly B lines because of pulmonary venous engorgement. Okay, so ECG, again you'll see bifid P waves. Okay, so P mitral, atrial fibrillation may be present. You'll have right axis deviation, RVBB. So echo is the most important tool to diagnose and confirm MS. Okay, so medical therapy, if there is atrial fibrillation, to prevent the clot formation, you should give anticoagulation with warfarin. That's rarely antibiotics, and you'll also give diuretics. See, in balloon mitral valvotomy, through the femoral artery, you will pass a catheter. Okay, if this is the right atrium and left atrium. So you will reach the right atrium. You'll puncture the interatrial septum. You'll enter into the left atrium. You'll go to the mitral valve and you'll inflate the balloon there. So contraindications, calcified, if there's a clot, and again, if there is associated mitral regurgitation, you will not go for balloon mitral valvotomy. You'll go for mitral valve replacement instead. Okay, so if there is significant all these conditions, you'll give. And you also have mechanical valves or bioprosthetic valves. Mitral regurgitation, it's a pretty straightforward topic. See, For causes of mitral valve incompetency, for normal valve to function properly, you need to have normal papillary muscles, normal caudate tendineae. Okay, and if anything is damaging the supporting structures, papillary muscles and caudate tendineae, that can result in acute MR. Chronic MR, it is due to chronic lesions like chronic connective tissue disorders like rheumatoid arthritis, SLE, etc. Okay, and any myxomatous degeneration of the leaflets or any rheumatic fever. Okay, chronic MR. Okay, and again, if there's a dehiscence of valve leaflets in infective endocarditis, or if you're doing balloon mitral valvotomy, okay, and you are causing a mitral regurgitation, that is acute. Okay, so caudate tendineae rupture. When can it happen? When there is blunt trauma to the chest, when you're doing CPR. Okay, when there is any Ehlers-Danlos or Marfan syndrome. And okay, papillary see, this can cause caudate tendineae rupture. Okay, connective tissue disorders, so Marfan, Ehlers-Danlos, blunt chest trauma, CPR. So papillary muscle necrosis, again acute MI. So it can cause necrosis of papillary muscles. So these are the causes. Okay. So again, there is volume overload to the left ventricle. Lot of blood is immediately filling into the left ventricle. See, acute clinical features, you'll have acute heart failure. So hypotension, pulmonary edema, left heart failure findings, you will have orthopnea, P&D, all this. Because there is no time for compensation for left ventricular hypertrophy to occur. Okay, so on examination, see, as soon as blood goes into left atrium, the pressure, the mitral valve is closed, left atrium enlarges, pressure increases, then valve opens, right? But here valve is already open. So it immediately goes. Early systole itself, the blood fills into the left ventricle. Okay, so early systolic murmur you will have. So gold standard is echo, and treatment is emergency mitral valve replacement. Then chronic MR, see, you'll have palpitations. Why? Because it is a regurgitant lesion. Okay, you have a hyperdynamic flow, regurgitant lesion, you will have palpitations. Okay, and in late stages you'll have heart failure and hypotension. On examination, you'll have a pansystolic murmur on expiration extending into the axilla. Okay, this is important. Pansystolic murmur. Okay, palpitations in MR. So again, treatment is based on NIHA symptoms. So 1 to 2, NIHA 3, 4. Okay, no signs of heart failure, greater than 50% left ejection fraction, no need of cardiac surgery, so medical treatment, beta blockers, ACE inhibitors, and diuretics. Okay, and again, on the other hand, you have to do mitral valve replacement surgery. So again, if you look at the book, so one thing you need to remember is, other than the causes which I already described in the diagram earlier, you also have dilated cardiomyopathy and hypertrophic cardiomyopathy, because the left ventricle is thickened. So it kind of contracts stronger, and at the same time the blood can regurgitate back through the mitral valve. Okay. So in these two conditions also, Lippmann-Sachs endocarditis can also cause mitral regurgitation because it's a chronic condition. So pathophysiology, in long-standing mitral regurgitation, increase in left atrial pressure may not be present because atrial dilatation is there, it accompanied. However, in acute regurgitation, there can be significant increase in left atrial pressure that can cause pulmonary venous congestion, pulmonary edema, pulmonary hypertension. Again, this causes right ventricular hypertrophy, right heart failure, all of this. Okay. So in acute cases, you'll have right ventricle involvement. Chronic cases, the left atrium has already adapted. Next, clinical features. See, patients will complain of palpitations. Okay, again, left ventricular failure, you will have dyspnea, orthopnea, P&D. Fatigue and lethargy, again because of reduced cardiac output as blood is regurgitating back into the left atrium. There is peripheral edema, especially when right heart failure sets in acute cases. Okay. So pulse, if there is AF, irregular. See, cardiac apex, it is displaced laterally and outwards. So so side and out apex due to dilated hypertrophied left ventricle. We also said HOCM is a cause, right? So apex goes outwards and more laterally. Next, see, you will have soft S1 and regurgitant lesions. Okay, MS, what we said we had mainly S1, so loud S1. So opposite MR, you will have soft S1 because of incomplete opposition of the mitral valve. Valve is not able to close only. So what it will produce S1? So you'll have soft S1. You'll have a pansystolic murmur because blood keeps on regurgitating throughout the systole. Okay. So pansystolic murmur is loudest at the apex. It may radiate to other areas and axilla. S3 also may be heard. So remember it as MR3. Okay, S3 also may be heard. Next, you can have, because of associated pulmonary hypertension, you can have loud P2. Okay, bilateral basal lung clefts can be present because of pulmonary venous congestion. So these are additional findings. Sometimes a short mid-diastolic flow murmur may follow the third heart sound due to increased flow across the mitral valve. Okay, so see, we talked about S3. Okay, so along with S3, you can have mid-diastolic flow murmur. Okay. Next, you can have signs of right heart failure, so raised JVP, hepatomegaly, peripheral edema, etc. So investigations, so chest X-ray, you can see cardiomegaly due to left atrial and left ventricular enlargement in chronic cases. So prominent pulmonary artery vasculature may also be seen due to pulmonary hypertension. ECG, again you can see left ventricle hypertrophy and left atrial enlargement. So those changes you can see. Echo, you can see the cause of the regurgitation, like is it a caudate and rupture or papillary muscle necrosis, or also the complications also if there's a clot formation, infective endocarditis, or any pulmonary hypertension. Okay. So medical therapy, as we already discussed, ACE inhibitors, diuretics, beta blockers, etc. And surgical therapy, mitral valve replacement. Mitral valve prolapse, it's also called Barlow's syndrome or floppy valve syndrome, or click murmur syndrome, so systolic click murmur syndrome. So basically there is myxomatous degeneration of the mitral valve leaflets. It predominantly affects the posterior leaflet alone. So basically what happens is there is bulging of the mitral valve leaflet more than 2 mm into the left atrium above the mitral valve annulus. So there is prolapse into the atrium. So epidemiology, again 30 to 50 years, females more than males. Etiology, it is usually idiopathic, but you also have some established risk factors, like for example, if your mitral valve annulus is too large or the leaflet is too large, okay, then it can prolapse. Then if the caudate tendineae are too long, okay, then also they can that can prolapse. And again, if there is any degeneration in the leaflet which can cause it to soften and go back into the atrium. So connective tissue disorders like Marfan's, Ehlers-Danlos, rheumatic heart disease, okay, and ischemic heart disease as well. So this is the etiology. So basically, you'll have palpitations due to underlying chronic MR. You will have chronic MR underlying to some degree in mitral valve prolapse. Regurgitation occurs that keeps pushing the valve to prolapse into the left atrium, okay. So because of that, you will have palpitations. You'll also have atypical chest pain which mimics angina and responds to beta blockers. So you'll have this is click murmur syndrome, systolic click murmur syndrome. So you'll have a mid or late systolic click. Why? Because see, in early part of systole, pressure is not high enough to open this valve, okay. Then mid part of systole, ventricular pressure is maximum, but the semilunar valves will open, okay. So that is why in late systole itself, blood flows back, okay, regurgitates. So there is late systolic murmur, okay. So before MR, there is a tautness in the caudate tendineae producing the click sound. So click, then you have the murmur. So click murmur syndrome, systolic. Gold standard is echo, treated as per MR guidelines, and prognosis depends on the severity. So basically, after discussing about the causes, the clinical features, see, most patients are asymptomatic. You'll have chest pain. It is in the substernal area with a stabbing quality, okay, maybe because of papillary muscle ischemia. Then palpitation and syncope, because there is autonomic dysfunction in MVP, it is common. So because of that, you'll have palpitation, okay, and syncope. And also TIA may be there, and sudden cardiac death as well, rarely. So physical examination, you'll have mid or late systolic click. This is called click murmur syndrome, systolic click murmur syndrome. So you'll have a mid or late systolic click because of increased tension in the caudate tendineae during systole. Then this may be followed by a late systolic murmur owing to some regurgitation. As the regurgitation increases, it becomes more of mitral regurgitation, so you'll have more of a pansystolic murmur. So basically, if the ventricle is small, okay, then the leaflet cannot go into the ventricle, it will go into the atrium, right? So maneuvers that make the ventricle size smaller, they will increase the murmur. So such a Valsalva's maneuver or standing position, because the venous return is decreased, the ventricle size decreases, filling decreases. So this makes the click and murmur more prominent, okay. So conversely, any squatting or exercise, they increase the LV volume, they diminish the click and murmur, okay. So that is important. Next, ECG is normal, sometimes non-specific changes may be seen. Echo is the investigation of choice. So you can see posterior movement of one or both mitral valve cusps into the left atrium during systole. You can also see any associated MR. And treatment, most patients have a benign clinical course, so no treatment is required. Some may progress to have MR, so you treat it accordingly. Okay, palpitations, again chest pain, you can control it with beta blockers like propranolol. Now let's move on to aortic stenosis. So normal aortic valve area is 2 to 4 centimeter square. See, it was 4 to 6 in mitral valve, 2 to 4 in aortic valve. Symptomatic AS, so less than 1.5 centimeter square. Severe is less than 1. Okay, so just remember 3 categories. Okay, so basically it is most common in elderly people because of senile or degenerative sclerosis of the aortic valve. In middle age, so 30 to 50 years, you can have a bicuspid aortic valve. Okay, so it's a structural abnormality, so there is faster degeneration. Then 20 to 30 years, young people, rheumatic etiology could be common. Okay, so clinical features, remember it as ASAD. Okay, so syncope, angina, dyspnea, they keep progressively increasing based on the severity. Okay, so syncope is the earliest symptom because see, the valve is stenosed, aortic valve, the cardiac output is decreased. So syncope, because of decreased cerebral perfusion, because of decreased cardiac output, you are having syncope. Then angina, it is most prominent, and because of pressure overload of the left ventricle, there is massive left ventricular hypertrophy because of increased demand state. And again, finally, dyspnea, it marks the onset of heart failure in a patient of AS. On examination, you can find, what can you find? Paradoxical S2 split. Okay, see, during ejection phase, you are ejecting blood through the aorta, right? That is when the valve is supposed to open. When it is stenosed, you will have turbulence. So, then you'll have ejection systolic murmur. So all are E's. Ejection systolic murmur on expiration, it radiates to external carotid artery, or remember it like that. And then ejection click also can be present. So ECG, because of left ventricular hypertrophy, you can find left axis deviation, LVBB, generalized ST depression, all that. Gold standard is echo. Again, based on NIHA class, you will take it as mild or severe. So mild you will manage with medical treatment, and severe you will go for surgery. So medical, you have to give ACE inhibitors and beta blockers and statins especially to decrease the sclerosis, so in senile changes. But you never should give diuretics to a patient of AS because already cardiac output is less. If you are taking out the blood volume also, then again it will reduce. So they precipitate hypotension. The nitrates also you should not give because they decrease the afterload. And again, aortic valve replacement. So yeah, that is a surgery. If the patient is at high risk for anesthesia or not consenting for the surgery, go for transfemoral aortoplasty. Okay. Then let's see what is given in the book. So basically etiology, you can take it, see, we had 3 conditions, but here you have valvular, subvalvular and supravalvular. See, supravalvular, all of them are above the valve, right? So what can you have? You can have familial hypercholesterolemia or hourglass constriction of the aorta above the valve. The valve is going into aorta. So aorta, you can have hourglass constriction or hypoplasia. So aorta is not forming, so valve also is closed like this. So aortic stenosis or any atherosclerosis of the aorta. So if it is near the valve, that can also cause stenosis. Familial hypercholesterolemia. Subvalvular, see, hypertrophic obstructive cardiomyopathy. What can happen is the interventricular septum is hypertrophied. Okay, this can also block the AV valve. Aortic valve. Next, valvular, you can have bicuspid valve, senile aortic sclerosis, and rheumatic heart disease. Okay, so these are the conditions. Next, pathophysiology. So the hypertrophied LV muscle mass, it elevates the myocardial oxygen requirement. So there is ischemia of myocardium. So there is obstruction to LV outflow because of the stenosis. Cardiac output cannot increase on exertion. You'll have syncope, angina, and dyspnea. SAD. Next, why is syncope there? Because of cerebral hypoperfusion. BP also can drop during exertion. Okay. Ultimately, you'll have heart failure. So a patient is usually asymptomatic unless it is moderately severe. So when the AS is moderate to severe, exercise induced syncope, angina, dyspnea, they develop. Orthopnea and PND may also be present if there is heart failure. So if there is heart failure, then the prognosis is poor. Okay. In physical examination, when you look at the pulse, because of decreased cardiac output, you'll have low volume pulse. Okay, apex beat is usually not displaced because normally it is asymptomatic till moderate or severe changes have happened. Okay, so unless there is LV failure and dilatation, the apex beat is usually not displaced. You can find a systolic thrill in the aortic area because of turbulent blood flow. Okay, high pressure, you are forcing blood in the ejection, so systolic thrill may be there. Auscultation, ejection systolic murmur. It is diamond shaped, so crescendo, decrescendo. So it is more severe the AS, the longer the murmur because longer ejection time is needed. Okay, So diamond shaped, crescendo decrescendo. The murmur is rough in quality, best heard in the aortic area with the patient leaning forward and breath in expiration. It radiates to external carotid, especially to the left carotid. Okay, so sometimes the murmur may not be heard in the aortic area and heard only over the apex, mimicking mitral regurgitation. That is called Gallivardens phenomenon. Okay. Next, you can have an systolic ejection click also before the murmur. Okay, presence of an ejection click suggests aortic valve involvement, and it excludes supravalvular or subvalvular causes of the stenosis. This is important. Next, again, aortic component, the A2 is delayed, resulting in narrow splitting of second heart sound in mild to moderate. In severe cases, you can have reversed splitting. Okay, so severity, low systolic BP, heaving apex because of dilatation. Okay, then soft A2 or paradoxical splitting. Okay, long ejection systolic murmur, and again orthopnea, PND, heart failure signs. So chest X-ray, you can see dilation of the heart due to failure. You can see cardiomegaly. Ascending aorta also shows dilation. This is called post-stenotic dilation. Next, ECG, you can see left ventricular hypertrophy, so everything on the left side. And echo, LV hypertrophy, thickened calcified aortic valve cusps, and again the orifice also you can see on transesophageal echo. Again, so it should be in severe AS if you consider a patient for surgery, you have to go for cardiac catheterization. Okay, based on I have symptoms, you'll go for medical management. And see, especially you have to use statins in old patients, okay, to slow down the sclerosis. Then balloon aortic valvotomy in patients in whom you cannot perform valve replacement because they're unfit for surgery or anesthesia. And in surgery, you have to go for aortic valve replacement. So aortic sclerosis, it is characterized by lipid accumulation and calcification of the valve. It is usually asymptomatic, okay. So you can find an ejection systolic murmur best on the aortic area, and carotid pulse and S2 are normal. So that is why there is absence of aortic stenosis. Carotid pulse is normal, it is not low volume. Okay, so then aortic stenosis is absent, sclerosis is present. Okay, ejection systolic murmur. So echocardiography, you can see leaflet thickening and all that. So that is why treatment gives statins. So finally, we'll be discussing aortic regurgitation. So the etiology, you can divide it into root causes, aortic root causes, and valve causes. So valve, see, basically you can have bicuspid aortic valve that is there in AS as well as AR, but it is more commonly associated with AS. Okay, then you can have endocarditis, rheumatic fever. Okay, you studied these two along with valves. So these two, they can affect the aortic valve. Next, you can have myxomatous degeneration. Okay, you can have radiation trauma. Syphilis is one important cause. Okay, and then ankylosing spondylitis. Aortic root disease, you can have root dissection. So aortic dissection, you can have Takayusu-arteritis, large vessel vasculitis, aortic root is affected. Then medial degeneration, okay, you can have Marfan syndrome, bicuspid valve here also, hypertension and all that. So basically there is LV volume overload because a lot of blood is getting regurgitated back into the left ventricle. So there is eccentric hypertrophy of the left ventricle. So that is why there is down and out apex, okay. So this increases LV force of contraction, so cardiac output increases. But because cardiac output increases, peripheral vascular resistance, it also ends up decreasing. So that is why diastolic BP decreases. Heart is perfused in diastole. So that is why cardiac blood perfusion decreases, okay. So symptoms and the mechanism. So remember, in aortic regurgitation, you will have palpitations because it is a regurgitant lesion. So P and D. So D for dyspnea, P for palpitations, and N for nocturnal angina. Okay, that is something you need to remember. So PAD or PND. So P, A, angina, and D, dyspnea. So then signs. See, pulse is bounding, Bispherian's pulse, you can see. Apex is hyperdynamic, down and out. So murmur, you can find an early diastolic murmur in the herbs area. So it increases on expiration and radiates to the apex. Other murmurs, you can find an ejection systolic murmur just like with AS, okay, because of hyperdynamic state at the aortic area. Mid diastolic murmur or Austin Flint murmur because of the regurgitation, regurgitant blood striking the mitral valve. So it is seen in the mitral area. Okay. So again, peripheral signs of AR, this is important. So just look at them like this. Okay. So first, forehead. Start from head to toe. So look at the forehead. So first, alternate flushing or blanching of the forehead with the pulse. Okay, that is lighthouse sign. Next, eyes, retinal artery pulsations in fundus examination. So that is Becker's sign. Okay. Next, look at the oral cavity. There is pulsatile uvula. So if you look at the oral cavity, so if this is your lips, okay, then you can see the uvula like this. Okay, so starts with M, next is U. So Muller's sign. Next, head nodding with each systole. So noddy, not this demoset sign. Okay, nodding, demoset sign. Neck, you can find Corrigan's dancing carotids. Okay, Corrigan sign. Arm, you can find locomotor brachia. Forearm, you can have water hammer pulse or Corrigan's pulse or collapsing pulse. Nails, you can find alternate flushing and blanching of the nail bed despite constant proximal pressure. So that is Quincke's sign. Abdomen, see, the liver looks like a thorn. You'll have rose thorns, right? So Rosenbach sign. Pulsatile spleen, see, look at the spleen, it is like this. Okay, so it is like a G. So Gerhardt's sign. Next, femoral, you'll auscultate without pressure, you'll get pistol shots, and with distal compression you'll hear Derhoy's murmur, and it is heard in diastole, Derhoy's diastole. Popliteal artery is easily palpable, so Lincoln's sign. Hill's sign, see, if systolic BP minus diastolic BP is greater than 20 mmHg, or some books say 40, it is Hill's sign. Okay, so chest x-ray, you can see cardiomegaly. So echo is gold standard investigation. You will see the regurgitation. Treatment again based on NIHA grades. You will think of surgery. Okay, so again etiology based on valve problems and root problems. So basically you talked about the pathophysiology as well. Drop in diastolic BP, and you also basically when left ventricular dysfunction appears, left ventricular failure, so you'll find orthopnea, PND, fatigue, all of that. Thickened LV wall also leads to diastolic dysfunction. Okay, remember diastolic dysfunction, and also you'll find PND. So palpitations and nocturnal angina and dyspnea. Next, signs. See, pulse is bounding or collapsing. See, systolic BP is high, diastolic BP is low. Okay, so there is wide pulse pressure. Systolic BP in the upper limb is at least 40 mg or more higher or more than the lower limb, which is Hill's sign. Okay, peripheral signs may be present. You'll have a down and out apex, which is forceful in quality. Okay, S1, S2 are normal. S2 is followed by an early diastolic, high-pitched blowing murmur. It is heard along the left sternal border when the patient is sitting and leaning forward. Okay, and also you'll have a regurgitant jet hitting the mitral valve, so that causes at the mitral area Austin Flint murmur, mid-diastolic. It can be mistaken for mid-diastolic murmur of MS. However, MS murmur is usually accompanied by thrill, loud S1, all that, which is absent in Austin Flint murmur. Okay, here S1, S2 are usually normal in AR. Okay, so all these are there. So pistol shot femorals, you also call them as Straub sign, and also something called Main's sign. So more than a 15 mmHg in diastolic blood pressure with arm elevation from the value obtained with the arm in standard position. That is Main's sign. So again, clinical assessment of severity. To indicate that AR is severe, see, look at peripheral signs. Bispherian's pulse. Hill's sign is more than 60 mmHg, hyperdynamic apex. Okay, early diastolic murmur lasts for more than 2/3 of diastole, and then presence of Austin Flint murmur. X-ray, you'll find cardiomegaly and sometimes post-stenotic dilatation of the aorta. ECG, again, features of left ventricular hypertrophy with the strain pattern you can see. So it is forceful contraction, right? So you'll find tall R waves in left-sided leads and deep S waves in right-sided leads. Okay, and echo, it's the gold standard thing. Cardiac catheterization, it's the most accurate way of confirming and assessing the degree of AR. And other tests, again, to rule out syphilis, to VDRL. To rule out connective tissue disorders, to A and RA factor, CRP, ESR. And ASO titers and throat swab cultures if rheumatic etiology is suspected. Again, vasodilators like ACE inhibitors, nitrates, hydralazine, etc. are helpful to reduce the afterload. So in AR, you reduce the afterload. Okay, AR afterload. So use these drugs. Again, digoxin, diuretics, ACE inhibitors, all of them are useful if there is heart failure, and treat the underlying cause if there is any disease, and go for surgical treatment. Also regarding Austin Flint murmur, it is a mid-diastolic murmur heard at the mitral area, a low-pitched rumbling murmur. Okay, so basically it is due to the aortic regurgitant jet impinging on the anterior mitral leaflet. So it may be confused with MDM of mitral stenosis. So it is in mitral stenosis there is loud S1, opening snap, and pre-systolic accentuation. All are absent in tricuspid in Austin Flint murmur.